So ARIES is comparing an early versus traditional versus late start for treat and extend regimen. Treat and extend is the approach most clinicians in Australia are using now, and it's actually the approach also in the United States and many parts of Europe. It's becoming worldwide. So ARIES is looking at extending the treatment interval by 4 weeks in one group compared to a 2-week interval in the second. The first year, one group will have 3 injections at monthly intervals. Then normally at week 16, the first extension to 8 weeks. The group with the early extension will then extend by 4 weeks at a time if signs are stable, whereas in the second group they'll continue at 8-week intervals for the remainder of year 1 and then start extending into year 2. What this means in practice is about 1 less treatment in the first year compared with the standard label, which is 3 monthly injections and then 8 weekly. And this brings down to this one saving of 1 from 8 to 7, or from 5 to 4 in the period after the loading doses is quite clinically significant and will be quite helpful for patients in terms of reducing the overall burden of therapy. Macular degeneration develops a late stage from the early signs. There are early stages of AMD, drusen, pigmentary changes, and then either patients develop neovascularization, about 2/3 of cases in population studies, or they develop atrophy at the level of the pigment epithelium. That's the dry macular degeneration or atrophic macular degeneration, about 1/3 of late cases. Wet AMD typically causes more severe vision loss and more rapidly, but ultimately many people with severe atrophic dry macular degeneration will also develop severe vision loss. It's really at the moment only the wet form that we have therapy for, and this is where drugs like aflibercept are very effective in stabilizing the disease process. Aflibercept is a molecule that was developed specifically to be an antagonist or to bind with VEGF, and it has particularly good binding affinity. And this is probably the reason it seems to last a bit longer than the other drugs. It also affects not only VEGF-A but also PLGF, and this could be important particularly for diabetic retinopathy, but may be also important in AMD as well. Traditionally, monthly treatment was the way to go, and the original trials with ranibizumab, the ANCHOR and MARINA studies used monthly therapy. And we knew that when doctors moved to an as-needed approach, often patients were undertreated. The idea of treat and extend is that while signs are stable, we can extend the interval between injections, but if in fact disease activity occurs, we can then reduce the interval again. And this tailors the treatment to an individual much better than a reactive PRN therapy. It's more proactive, and the results really have now been shown to be substantially better than using PRN and equivalent to monthly. The treatment regimen is really quite important. Disease burden is a major problem with AMD. People have difficulty getting in very frequently, so that if you can tailor the treatment to a person's needs, therefore you can reduce the number of injections and visits. It means that people will have an injection each visit, but that's a very efficient use of the drug. And it's shown now, and certainly the ARIES trial shows, that we can extend patients a bit faster than we thought before, and that will also reduce the burden, at least in the first year, and hopefully in the second year as well.